Good evening and welcome. My name is Mark Kinney, and I'm the Senior Vice President of Member Relations for the Independent Pharmacy Cooperative. Tonight, as part of the IPC webinar series, we are pleased to present IPC's own John Cabello. John joined IPC as a Director of Government Relations in 2014 and has over 3 decades of federal, state, and local government affairs experience. John also spent several years working for 3 congressional offices in Washington, D.C. I will now turn the program over to John.
Cabello, I'm IPC's Government Relations Director, and we're going to spend the next hour doing an update on both federal and state activities that have been going on related to pharmacy. I'll be covering, obviously, what the election means at both the federal and state levels to this, sort of looking at what we've been dealing with in 2020 and what we expect to happen in 2021. We've gotten some questions that people have already had. You'll be seeing the slides. I will be referencing things in the slides, but you will get copies of them, so you will have that information as a resource. And we certainly in the chat can have questions as they come in, but if we can't get to them all, please send them in and we will take time tomorrow to respond to all of them. So without further ado, I'm going to start. Obviously, at the federal level, a lot of what we all have been dealing with throughout the country and certainly our industry since March has been COVID. That has really consumed everybody's professional and personal lives. First off, we were involved in what Congress was doing, and obviously everyone knows that the CARES Act had some basic 4-part provisions that Congress passed, starting with payroll protection, giving small business additional protections, provider relief funds, and we keep hearing from stores there were 3 rounds of those who've gotten different aspects of some of the money. Some of it wasn't very clear was available to pharmacy, but we are heartened to hear that pharmacies were taking advantage of it and realizing it was a bit arduous to get some of that. Medicare, obviously, there were federal changes to allow for 90-day refills and provide for vaccine coverage under Part B, as well as expanding FSAs and HSAs to cover over-the-counters. And there also being greater incentive for FDA approval to get products to the market. Specifically at the administrative level, it's been a flurry, and IPC has been very involved working with a lot of players in our industry to move these things along, to help pharmacies deal with the change and the demands given COVID. There have been a host of both Medicare and Medicaid actions that have taken place administratively for both Part D. Obviously, the flexibilities were the biggest things at the beginning that were needed. It's very important. There were supposed to be no audits during COVID-19 or during any of the emergencies, but it's very important we hear from anybody if they start to see audits reoccurring. It wasn't very clear that they would stop them for the perpetuity, but it was really during much of the initial indications they would not be doing live audits for safety reasons, but now it appears they may be going back to doing desk audits. They've also provided flexibilities in the star ratings to ensure that stores aren't penalized during this process in upcoming plan years for how they had to change and operate during COVID. And obviously we all know about the testing and the influenza and other vaccinations that are now a part of this, and enhanced matches that people have gotten for Medicaid and even for home delivery. I would say make sure on any of these things that you're following very closely, especially when we get to the vaccines, any of the registration, data reporting, storage requirements, any things that your state health department is going to tell you have to do as part of that. And obviously HHS took very, very significant actions this year, which we're all pressing for, to allow us the testing authority, as well as the vaccine administration and the childhood vaccinations, even for influenza, down to age 3. It's very, very promising what HHS has done is this, that we can lead to more permanent policy change. But the one thing they've made clear in questions is the HHS standard of lowering that down to age 3 and the requirements for influenza is the floor. If the states are more liberal with what they're allowing pharmacies to do, they can in fact follow those. So what the federal government did was create a floor, not necessarily a ceiling of how to practice. And there was even compounding relief that was provided on some of the requirements the FDA requires of compounders. Beyond COVID, we've obviously not lost sight or purpose on focusing on other important matters affecting pharmacy. Through both the COVID rulemaking process and the normal rulemaking process of CMS, we were actively involved in promoting and pushing for change to fix DIR. We know the DIR problems have not really gone away. Unfortunately, because of their view of it having an impact, they did not change it this year. There's also been, and I'll talk about that a little more, the other big thing was obviously a lot of work before COVID and really a spillover from 2019 of significant progress in congressional consideration of drug pricing legislation, where all of us in the industry really pressed very hard and got some success of 2 different bills, really 3 different bills having some traction to deal with moving point of sale DIRs, as well as other looking at pricing changes, but also to require in any states that are using Medicaid Managed Care that they end spread by actually requiring transparent cost-based reimbursement to the stores, and that be the only basis of what the PBMs could charge a state Medicaid program. Obviously because of COVID, but really because of a lack of effort at making this the priority to develop a consensus. These bills are stalled. It's unlikely any action will take place in any lame duck action, and it's something that obviously will have to be picked up for 2021. Moving forward, specifically though on just the administrative actions on drug pricing, obviously they did withdraw the rule, which was a bitter disappointment to us all. They bought the arguments it would adversely impact premiums without really having enough analytical data to show that. But we certainly will keep the pressure up on that. So what that really means is the earliest any change could happen to DIRs would be plan year 2022 because of the process involved for them to design the program and then have PBMs submit their bids to CMS for Part D coverage. You may have been hearing some things in the last few days about particular actions that may be happening. The President took 2 actions by administrative actions that now he may finalize in rules. One is an elimination of drug manufacturers' antitrust safe harbor for rebates, which the goal there was to be a direct pass-through rebate, bypassing the PBMs and going directly to the net benefit of the Part D recipient, really trying to instill a true net pricing for the cost of those drugs. The other thing he is talking about is looking to potentially have adoption any day now is a most favored nation status for drug pricing, which would allow the federal government to pay for these drugs at what is the equivalent pricing benchmark used in other industrialized countries. He did take other actions on drug importation to allow it, although when the state of Florida just recently tried it, nobody bid on the efforts to do the importation. And he made some pricing reduction changes for EpiPens and insulin, primarily in the 340B program. Moving forward, I'm looking at all of this, so we'll have to see what actually transpires as the administration, as expected. We see that President Joe Biden is in fact certified as the president, will be inaugurated on January 20th. What other actions they may take on these in the last few weeks of the Trump administration. But where we sort of start, I'm sure you all have been paying attention. Joe Biden carried 25 states, even though they're different process he's right now certifying that with 306 electoral votes. So it is fully everyone's expectation he and Kamala Harris will be inaugurated as president and vice president on January 20th. In the Senate, with 2 pending runoff races in the state of Georgia on January 5th, the Republicans can do no worse than a 50-50 tie. And if they win one or both of those seats, they will retain control of the Senate, with Mitch McConnell staying as majority leader and still chairing all the committees and, most importantly, setting the legislative agenda. On the House side, it surprised everyone. Rather than gaining seats as was expected, the Democrats have actually lost seats. There are still 4 races that are not been certified yet as to who won, but right now the Democrats hold 222 seats. You need 218 to control the House. So the net gain for the Republicans may be anywhere between 8 to 11 seats. Critically for our industry, we've got more advocates that know pharmacy and know pharmacy issues. That's adding to the ranks. I'd like to call it adding to the buddy brigade in the House. As you know, Buddy Carter's the only pharmacist in Congress. Coming January 3rd, he will have 2 additional pharmacy owners, Jerry Carl in the 1st District in Alabama and Diana Harshberger in the 1st District in Tennessee. And she is going to be a great addition on healthcare issues. She does a fair amount of compounding and long-term care services. She's really very intricately involved in many complex areas in pharmacy and has a fairly rural district, so she will be a very important voice. Also from the state of Montana, their at-large representative is their state auditor, who is also the insurance commissioner, Matt Rosendale, and he's done a number of reports and regulations and promoted legislation to regulate at state level the PBMs. He is looking to take that experience and knowledge and apply it to the need for federal policy changes at the federal level. And I know we've all been giving him plenty of information about the danger and the damage DIR fees are doing to patients and their pharmacy providers. So we do have many, and in the Senate, just to touch on that, House member Roger Marshall, who is a doctor and has been a big proponent of pharmacy's role in rural areas and the need to expand what pharmacies can do, as well as eliminate many of the practices of the PBMs that harm their abilities to do that, will be a new member of the Senate. I fully expect him to be an active and engaged member of the Senate Pharmacy Caucus, so that is a very good addition for the pharmacy community, having him go to the United States Senate. Overall, you know, we still have many pro-pharmacy members that are going to be in the Senate. There's a very good chance Representative Kathy McMorris Rogers from Eastern Washington State will be the ranking minority member on the House Energy and Commerce Committee, where all pharmacy issues flow through. That will be a very important change in their leadership. I would say the only person we really lost, unfortunately, who was a very strong advocate, was Representative Doug Collins from Georgia, who left to run for this unsuccessfully for the Senate. The bottom line, though, is of all of this, we're going to have to see bipartisan agreement to get any legislation done. But there's already been things being looked at. What will the Biden administration be able to do administratively through regulation, other policies, or emergency orders, or executive actions, even advisory opinions of agencies? So what should we expect in 2021? I think this will come as a surprise to no one. First and foremost, dealing with the COVID pandemic response will take up this administration's first 6 months, even with all the wonderful welcome news this week of vaccine development. There's obviously been a lot more focus on that process and the supply chain distribution of what's going to have to follow to get that out. I'm sure all of you are going to be looking, and certainly IPC is putting information out there, and I know there's a lot of from throughout the industry of how and when pharmacies will be able to get this working. Look at your state's health departments as key sources of information on how they will be working through this distribution. Now that we have the authority, and I know it's been covered in other places, that independent pharmacies through different PSAOs and different other organizations can be considered a part of a pharmacy network for these vaccines, it's very important for you to get your ducks lined up now to be a part of that. But we're taking that fight a step further. The COVID has given so much attention to pharmacy since the outbreak. I've been in this industry for nearly 15 years. I've heard more about policymakers and the press mentioning pharmacy in these past 9 months than I did in the other 14 years. And then we're looking at this as our opportunity to finally get them to recognize we're a critical part of the infrastructure they need to respond to healthcare needs in this country that has been woefully underutilized and doesn't have the policies in place to make that happen. So to that end, we've been working diligently with a lot of other stakeholders in this to make the priority in whatever the next COVID package is, the phase 4, whether they do it in lame duck, whether it's come up early in the next administration or it takes time through the legislative vehicles to get this addressed and make sure that they add Medicare Part B provider status for pharmacies. There are efforts solely to limit it either to COVID or to public health emergencies, but it's really important, since this is our best opportunity to get this, that we make the case. And now that they will have data to show where pharmacy has been an added value, not a cost, for us to make the case that since most payers follow Medicare, it's time to include us in the Medicare Part B provider status, billing status, as many other affiliated practitioners such as nurse practitioners and physician assistants have, to be able to bill directly for Part B at a discounted rate of what is the payment schedule for doctors. So please pay attention to efforts on this. It's going to be something that's obviously going to have to be pushed, as well as other things of expanding PPE, another round of PPP, other elements that may provide protections of pharmacy, but this really is our best opportunity. It really is a now or never situation for us to make the case. Obviously, we will look at efforts for DIR reform. There is a window. You'll see it here on the slide. We have the first 6 months before they'd have to design the plan. And that would be for it to go into effect in 2022. The rule can be brought up if they're going to do more Part D changes, since they have to do it all by rulemaking. There's push to end DIRs during the public health emergency of COVID. That's not off the table. And we'll have to see if they do adopt the safe harbor rule, eliminating PBMs having control of the rebates, what that really means for whether they should be having DIRs. I have a note in here that, we know the impact that DIR fees are now 3 to 5% of an impact on your revenue. So we certainly have it and will not lose sight of this as an important policy issue that we're going to have to look at whatever opportunities there are in Congress and in the administration to get it addressed and get our pharmacy advocates on Capitol Hill engaged to have this done. Very quickly, 2 other issues that will come up going into 2022 on compounding. The FDA is looking now to get states to enter into memorandums of understanding for implementing compounding rules that the states would enforce. They've also recently put out a guidance document, which we'll have available on our website, since there have been some reports of insanitary conditions in some sterile and non-sterile compounds for what stores have to follow. So the FDA is not forgotten about its role in trying to push compounding. And finally, 340B. Many of you may be doing 340B. Everybody was very alarmed at manufacturers trying now to limit access to drugs to contracted pharmacies that are dealing with covered entities, 340B, where there are more than one pharmacy involved. There have been talks of lawsuits, more agency reviews, a dispute resolution process, and there may potentially be congressional action. We certainly will be forthright and strong in promoting that we need to protect these critical access points of pharmacies being contracted pharmacies, and often in rural areas being the only point of care for covered entities, that it'll be critically important to keep that going during this time of a national health emergency. So that, you can see we've had a lot that we've had to deal with in 2020, and it will all continue to be the major focus for 2021. But we know right out of the gates, dealing with COVID and the opportunities for more policy changes to help pharmacies be a part of the solution is what we'll be primarily dealing with when a new Congress and new administration comes in January. Shifting now to the states. Basically, the election was a status quo election for the states. Only 2 states were really seeing a change in their governorships, switching parties, other than New Hampshire and Alaska changing control of their legislature. Minnesota still remains the only state with a split legislature, and we have 31 Republican-controlled legislatures and 18 Democratic controlled. So not really much of a change as to the players we're dealing with. As to the party control, because of term limits in states, there obviously will be change in many legislatures' makeup of actual members. Obviously, one of the big things as we look forward, since there was a lot of focus in 2020 at the state levels on dealing with COVID, but this seemed to me the most appropriate place as to where to put it in this presentation, is the Rutledge case deciding before the Supreme Court what states can and cannot do. I'm sure many of you are aware, or all should be aware, the Supreme Court heard the case on the 6th on the critical issue. Does Arkansas's law regulating MAC pricing, is it preempted by ERISA? And it's a question of that. Does the court's precedence on other ERISA preemption cases and healthcare benefits plan design apply here? Or is the state fully within its rights, as it does with other regulation of consumer pricing, have the right to regulate how the PBMs go about utilizing their MAC prices? As you know, both the U.S. government and 43 state attorney generals supported ERISA's Arkansas's position. There was no ERISA exemption preemption because there is in fact no direct relationship between the plan sponsors of and the PBMs, since they all go through the health plans, and the PBMs are third-party contractors. We did support IPC, a brief to have NCOIL, which is a national group of insurance legislators, argue for the right of states to regulate and pass legislation. The court hearing was trying to raise a lot of issues to get them on the table. The decision will take place anywhere between January and the end of their term at the end of June. I've yet to talk to an expert Supreme Court litigant that would be willing to wager any bet on how they will rule or when they will rule. But clearly, absent knowing what the rules will be as to how much the states can regulate, many states held off on doing any significant PBM regulation. In fact, in New York State, Governor Cuomo vetoed a PBM regulation bill strictly over the issue of ERISA and labor law preemption. It's very likely we will know after this case how much the states can do and where they can do it. Although I will add, this just happened this week. North Dakota is appealing a case where they had it struck down their law, and it struck it down in its entirety, applying to the state. And that may even be more relevant since that's an insurance statute, whereas Arkansas is not. So other federal laws giving the states the right to regulate insurance come into play. So these battles may not be over. To put it in context, here's a map that you'll have available to you. A number of states that you see circled have really strong, good PBM regulation laws on the books. The states you see boxed out are involved in court challenges where all this may come down. 3 national organizations focusing on health insurance or healthcare policy have all adopted or are in the process of finalizing model bills for states to use to regulate PBMs. And at a minimum, they're all looking at full licensure. And the consensus in that is no matter what the Supreme Court rules on whether ERISA preempts states from regulating PBM benefit issues, the notion that they can still license and require them to be licensed by their states as entities operating in their states, there is a consensus that the Supreme Court cases will not strike down that right. So there really has been, that's why I put it here in yellow, a consensus that everybody's seeing a need to move to full licensure of PBM separate and apart from health plans in their states. So pay attention to the court cases. That'll tell you what really our opportunities are to move forward on PBM legislation. Any early states may not have that opportunity before their legislatures adjourn in the first half of 2021. To another issue that we've really seen a lot of attention the last couple of years, but in this past year, we've had a lot of progress and a lot of positive progress, thanks to the work of a lot of stores and the industry of showing the states Medicaid managed care prescription drug carve-ins have not worked to save them money. In fact, it's cost them money. You probably have all seen different reports and analyses out there of what it's cost states to have Medicaid, the prescription benefit carved into Medicaid managed care. Well, now we've been pushing and working with a lot of industry partners around the country to actually make that action happen, to change it. Most significantly, California is already moving to do pricing surveys. They have had a plan in place for over a year and a half that starting January 1, they will take all of their prescription benefits in managed care in California's Medi-Cal program, put it back into fee-for-service. That will be a huge benefit to both Medicaid patients in California and to their pharmacy providers to get true cost-based NADAC and a true cost of dispense fee payment. Similarly, based on a report that came out much later from the comptroller in the state of New York in its budget back in April is moving to a carve-out. That is really a major policy shift. Governor Cuomo was one of the first governors to promote managed care for prescription benefits, but seeing that it cost them over $500 million, an added cost of PBMs managing the prescription benefit. There was a prevailing view with a push for a bill, but it got into the budget to carve it out. And I got to give a real shout out to PISNY president and an IPC member, Steve Moore. He put together a very effective coalition through FixRx to push this. And it's an example that we have changed two of the biggest states. Moreover, in Kentucky, through a lot of hard work of people like Rosemary Smith, who is an IPC member who runs the Kentucky Independent Pharmacy Association and other groups in Kentucky, they got in place after 2 years of effort that MCOs starting in January are going to have to use transparent cost-based pricing reimbursement to the stores as the basis for their charges to Medicaid. That's a huge relief in Kentucky, where it was over $200 million in spread that PBMs are getting away with. And to cap off the most pleasant change we got after it had gone through many fits and starts, in the budget that was adopted very recently in the state of Michigan, after they had backtracked from doing a carve out, they did the Kentucky model, or some of you may be aware, the Kansas model, where it has to be this transparent published pricing, payments to stores with a cost basis fee for what pharmacies will have to be paid by managed care entities in the state of Michigan starting in as early as February of next year. Ohio continues to move, which really started a lot of this, towards more transparent payments. They're not there yet. They are actually now starting to pay $100 million in additional pharmacy fees to be a bridge gap to reform. They are moving and have 5 bids received for a single PBM, but a PBM that will not control the benefit design. For that, they've already started to move. They ask for consultants to submit bids to become the state's consultant to designing that benefit. And we expect all of this to be in place early in January, and the AG is even looking at legal actions, broadening legal actions against PBM for what they viewed as fraud for how much they've overcharged the states. Pennsylvania is making efforts to reform. We've been very involved in a coalition there. We hope to get a bill to allow the auditor to fully audit PBM contracts, which he currently doesn't have the authority to do now, and to do a state-funded study. Our goal is in lame duck we can get that done, so that is have the results early in 2021 to make a push for a bill to require transparent cost-based payment as well. Georgia's going to have a study that's completed by December, which will spring into legislative action early next year Maryland and Florida are among states as well as Virginia who have done studies and are going to have legislation in place to either end steering, as has happened in Florida, but really in Maryland and Virginia, look to end through a carve out or these transparent payment requirements, a fix to the problem like West Virginia did. So what does all this really mean across the country? Well, this map really gives the best illustration of it. Any of the states in blue are fee-for-service states. You see where I've highlighted in green New York and California moving to a carve out, and Michigan now joining, and Kentucky joining Iowa and Kansas and Mississippi and Louisiana, a number of other states that require cost-based, full cost, transparent payments to pharmacies as the basis for how they run the prescription benefit and managed care. All these other big states you see that we haven't talked about, Illinois, Texas, they've all looked at doing studies, as have a number of the smaller states. Massachusetts is looking at it, and I understand New Jersey may be taking a look at this as well. So most of the states have understood that this experiment really didn't succeed in saving them money, and now it's just a matter of getting enough data and studies that show the facts and giving them this pathway to follow what these other states have done to finally fix the Medicaid Managed Care prescription drug program abuse by the PBMs. And we are still hopeful that the federal bill I talked about earlier will have the opportunity to do that. Very quickly on provider status, you know, a number of states have moved to give pharmacies more authority. We are hoping to see this move beyond just COVID to a broader sense of what pharmacies can do under existing state authority. It's not about changing the Practice Act, it's about the ability to pay for it. The pandemic has really shown the broadest need for this. It is showing where we can fill in the existing needs and where it has to be done. So far, there are 6 states that to several degrees have now moved or have legislation to give this kind of authority for pharmacists to be considered state provider status to bill under their commercial insurance and to some degree their Medicaid programs, that they can get medical billing. And this is really critical to understand. This would not be the traditional store model of prescription benefit. This is added enhanced services in the medical area through medical billing platforms and requirements of credentials that would be similar to what nurses and physician assistants have to abide by for pharmacists to finally get paid for what they've been trained and licensed to do. Get paid to fully serve a patient. And in a time of the health crisis, I think more and more policymakers are seeing the need for this. Here's sort of the lay of the land of where the states are. You know, this map's a handy guide. Really, Ohio probably and Washington State have the broadest laws. Tennessee has a very broad law that puts them in the same bucket as other providers, that what they've allowed chiropractors and other providers to do, pharmacists can bill for too. Washington State has been the furthest along with this. Ohio is just now putting into place regulations that we hope to see them adopt based on our input early in January. Equally important in this in Ohio, they've started a pilot program started by the health plans, significantly United Healthcare and CareSource in their Medicaid Managed Care program to pick a number of stores as pilots. It has included Shriver's Pharmacy and some other IPC member pharmacies in the state now that are a part of this pilot program, along with a few others. This is an initiative driven by the health plans wanting to fully utilize pharmacists to help them be a part of the solution. Somewhat, it may be in response to the criticism and attacks they've been taking in Ohio for the prescription benefit part of it. But this is really, I think, being driven also by the pandemic. They need every provider working to help them contain the cost as Medicare demands is up by enrollment increases, but also in the middle of a pandemic, people's healthcare needs being greater. So there's a lot of interesting developments out in Ohio on that. That really will be a significant marker to look to, as well as with states like Tennessee, which just passed their law a couple of years ago, and New Mexico, and Texas trying to join the ranks to actually be able to set in place policies where plans will have to allow, under proper credentialing, pharmacists to become providers for healthcare services. Now, it will require stores to work with their software vendors to get the proper capturing. You will have to really assess your pharmacy operations of your physical space and your staffing to meet these needs. But in many areas, from diabetes management to tobacco cessation to contraception therapies to hormone replacement therapies to COPD and hypertension, whatever your state's practice law is allowing pharmacies to be involved in doing. Many are even looking at an interesting one, a very positive one in Ohio. They want pharmacists now to be involved in helping them meet the behavioral health needs of Medicaid patients as a part of their provider billing status regs, because they don't have enough psychiatrists, they don't have enough mental behavioral health practitioners, and many of them they need for crisis intervention. So we're starting to see a corner turn. There's been a very interesting pilot being done out in Iowa, driven by their Blue Cross Blue Shield, to pay a per month per patient fee to pharmacists that participate in a program to actually manage overall their care. And obviously a lot of this is beyond what's being done, or in tandem what's being done with the CPESN enhanced national networks. But this is really what we see as a driving area for opportunity to promote something that pharmacy is for, that benefits everyone. And it's also a unique area where you have the payers and us as providers on the same side, not us being contending forces going to state policymakers fighting over PBM issues, but where they'll see us on the same side. And we've seen in the states that have done this, having hospital groups, trade groups, nursing home trade groups, and the clinic trade groups, all in support of having pharmacists do more, because it helps them avoid patients getting worse, but also being able to fully maximize our ability to fully serve the patient and deal with the medical home models that everybody's talking about, and that some of the payment systems are now starting to penalize them on if they are not meeting those goals and those outcome standards. So look, we certainly will be involved in a number of states to push these bills. There's a number of states that we talk to, and we know others out there. We're very involved with NASPA, the State Association of State Pharmacist Associations, and we know a lot of state execs are really looking hard at where they need the payment insurance laws now to catch up to their Practice Act's expansion of what pharmacists can do. But it's going to take all of us involved showing that there's data out there to support this, what needs to be done to change the laws or policies, and find the willing coalition members in each state to promote this as being, it's not just about this being good for pharmacy, it's good for patients, it's good for the overall healthcare provider needs, and it's really good for the bottom line of everybody worrying about the rising cost of healthcare. So I would implore and encourage all of you to take a serious look at this as it's happening. If you're in any of these shaded states, get familiar or send me questions you have as to what's being done and what's allowed in those states to bill. Many of it is you still have to get into their networks. And as I said, at the end of the day, you will still need your software provider to be able to help you build those not only the billing platforms, but the data collection capabilities you're going to need in order to become a healthcare provider to bill for your time and services. So here's a chance where payment practice will follow the payment, because the payment opportunities are there. Very quickly, just one other major issue I wanted to touch on. Opioid taxes are still out there, affecting pharmacies. There was a big story this week in Fortune magazine about how New York State's tax is in fact severely restricting pharmacies' access to necessary pain medications for legitimate pain patients. No bills advanced this year. Oregon and New Jersey did have them introduced, but they didn't go anywhere. New Jersey will probably see that on its political docket in the legislature again next year in its budget process. But we are certainly keeping an eye on this, and there has been a growing coalition of providers and patient groups arguing against this as not being the solution to the problem. And I'm sure you're aware there are many settlements being offered by opioid manufacturers that will really give the states the resources to tackle this. And I do think the Biden administration will look at other needs for resources to continue to tackle the opioid problems in the pandemic. So those are sort of where we've been looking at and where we see things going in the state and federal level. And just very briefly, just for your advocacy, guys, I always do this at a session whenever I'm asked to speak. People always ask, why is this stuff so difficult? Why can't they just see it and make it happen? Or why do we have to keep fighting for this? Well, there's a few lessons I'm going to leave you with, and then certainly if there are any questions we have at the end, I want to leave time for that. You know, in government relations, anybody who's involved in this, it's a marathon, it's not a sprint. You don't just get things and then it's done. There's implementation issues, there's follow-up. You find the laws don't work as you anticipated. And as we've seen in the PBM world, they'll figure out another, it's a whack-a-mole, they'll figure out another new trick to pull so that we'll have to go and address a different abuse. So you never really finish this. The other thing that I know it's a difficult thing to accept, but it's the reality in anything in politics. That's one thing I've learned in decades of doing this. It's always easier to kill a change than to get it adopted. People advocating to keep the status quo always have the advantage by the nature of our governmental system being very slow and having separation of powers. We had a saying when I worked in the legislature, it's always easier to kill a bill than get it passed. And that's what the PBMs do. They look for ways to thwart our opportunities to advance it. But we're making progress, but you do have to realize that's the systematic obstacles we do face. The other thing we'll have to keep in mind of is we can't let our pursuing the perfect be the enemy of the good. Many times we won't get everything we ask for in a bill or a regulation or getting government to change its policies. But oftentimes we should look, we always got to take the best of what we can get and realize we'll go back to fight another day. And as I said, it being a marathon. But I don't want anybody to get discouraged. That's why, you know, I hope you saw we had a lot of very, very positive developments of success and progress as an industry we've made this year, while we've had to deal obviously with some very bitter, frustrating disappointments on things like DIR and not yet having full federal full-blown provider status. But it's important to stay engaged, to stay energized, and to stay active in pushing this. I know on the Part D rule, they said that they've got the most comments on that ever in the history of CMS. Think about that, that's 55 years. One specific rule on a specific discrete program requirement generated the most comments on anything bigger than any doctor or hospital or nursing home issue. So keep that in mind. You have to always keep advocating, because if we give up, if we go away, we stop pushing our agenda, we don't just get forgotten. That's how you get destroyed. And you may have heard this adage, if you're not at the table, you're on the menu. And what that really means for us, what I try and advise everybody whenever I'm asked to give a talk, is pharmacy needs to learn the lesson like doctors, dentists, and hospitals, and even nursing homes did a long time ago, that you got to be in these public policy arenas because your livelihood depends on it. Because it does. They learned a long time ago government actions were going to control how much they made and if they were making money, and they got political. And I'm heartened by the fact that we've had pharmacist legislators elected in state legislatures, but more importantly, we're now back to having multiple pharmacists in Congress. And we're getting other public officials elected who are dealt with pharmacy issues in their other elected or appointed jobs, where they're all seeing how pernicious the activities of PBM are harming patients, harming the payers of the ultimate bills, and the providers, the pharmacy providers that they're depending on to be giving these valuable services. So let's keep doing that. And I'm going to give you one last motivational slide I give at every speech. Please take this, print it out, paste it on the wall of your work areas for you and your staff. I've seen this in union halls. I've seen it in other organizing groups whenever they feel they're up against the impossible. You'll see the frog may be in the mouth of the pelican, but the pelican can't swallow him because frog's got his hands around his throat, making sure he can't swallow him. So never, ever give up at fighting for what we need to do to serve our patients, to serve our communities, for you to keep your small enterprise healthcare centers there. And in a time of pandemic, hold them to the performance on the promise that they see you're vital by working towards these policy changes we need to allow you the ability to fully operate at the full height of what you can do and to operate profitably so you can continue to be there and invest in serving your communities and your patients. And with that, I haven't seen Linda if we have any questions. I know some I've gotten along the way is on DIRs, people were asking me, well, why did they believe? Haven't they seen how much they've been collecting? Why don't they see that if they get rid of these, it would be better in that, you know, they see the pharmacy losses, but how is it they think it's going to raise premiums? Well, a lot of this is based on actuarial analysis by the Department of Health and Human Service and Congressional Budget Office, where they're listening to certain assumptions of the plans. And that's always dangerous when you consider the source. The drug manufacturers actually know what's happening with the rebates. And remember, DIRs were supposed to be a way of them accounting for rebates that would come through that are supposed to be accounted for. Well, they've now totally manipulated this system in a way where it's far beyond that. And that's what we're needing to address. I know that the manufacturers have studies showing how this is costing patients money. Plus, remember, it's artificially inflating every Part D patient who hits the donut hole. It's inflating their trigger to get in the donut hole. Did have a question come through of how PBM legislation to pass increases reimbursement providers, if at all. Well, you know, that's an interesting question, because one of the things it may do is change some of their practices for how they handle rebates. Network adequacy and network mandates could be a part of that. Their practices certainly on drug price generic reimbursements would certainly be a part of that. And remember, a big part of one of the issues at the Arkansas law was that they could not pay themselves in their own pharmacies more than they would pay any other network pharmacy. So part of what these groups are looking at are these kinds of regulatory things. Patient groups, consumer groups are pushing for fiduciary responsibility. Now, that doesn't directly benefit pharmacy payments, but if they were made fiduciaries to the plan, they'd have to be making decisions on drug formularies and pricing that's in the best interests of the plan sponsor, not the PBMs. A lot more of the transparency also will push more towards not only cost-based reimbursement on the drugs, but it really will open the avenues for more enhanced services of what pharmacies can do. The other question I got on COVID is, well, do we really need all these changes in scope since they've taken all these actions at the state level for COVID and now all these federal authorities? Understand the actions all the states, and specifically and particularly what the federal government has taken, are related to public health emergencies. Those changes, while they may recognize the need and have made policy changes to get pharmacies involved and give them the authority to act, they will end when both the federal and state public health emergencies related to COVID are no longer in force. It'll sort of be setting the clock back to what will happen then. That's why we really are urgently pushing for provider status. Federal provider status will set the bar and set the stage, since so many states and so many commercial players benchmark off of Medicare to get us into a permanency state for that. There may be future efforts if, God forbid, there's another national public health emergency to basically re-up pharmacies. But I don't have to tell any of you that kind of haphazard approach doesn't allow for you to fully make sure that your pharmacy and all pharmacies are a part of the critical health infrastructure this country has seen through this pandemic and has planned for, that they need to deal with public health needs. Finally, one other question I've been given is, what to expect, or when we should expect the Supreme Court ruling in Rutledge. And what about the fact that now there's a 9th member? They heard the case when there were only 8. With any of these cases, and this has happened in the past when they've had vacancies, it still takes 5 votes for the Supreme Court to make a decision. As long as 5 of them are in agreement, they can rule. In the possibility, I should say, of there being a 4-4 tie, there is a possibility they would rehear the case. However, given the fact that now North Dakota has moved to have their case granted certiorari, if the court can't decide where they are on Arkansas and needing a full complement of 9 members, they may say that they can't, that there's a 4-4 decision, and then they may grant the hearing for the North Dakota case. Like I said, every expert I talk to is loath to predict what the Supreme Court will ever do. But if past practices hold, they will probably make a decision on the case sometime in the first quarter of 2021. Just to understand, their practice is usually the week after they hear a case, they meet as a court in their private consultations to discuss and decide the case. So much of the construct of where the vote is, it's certainly kept very secret, and rarely does that ever leak out. They probably already decided what they're going to do with the Rutledge case. Now it's a question of what they have to do in their internal operations to develop what those positions mean and write opinions before they would publish it. Just got a question about another round of PPE. I think certainly with the change in administrations, that's one of the things I did hear in the news today, that presumptive President-elect Biden is talking about, that there's going to be a need. He had a group with frontline healthcare workers talking about needing to get them more PPE. As for another round of PPP, I think that's going to depend on whether and how they can reach a consensus between Senate Majority Leader Mitch McConnell and presumptively President-elect Biden as to what's going to be needed as a major constructive relief package. Obviously, help to the states and local governments, help to specific industries, and something more targeted to small business needs will probably be there. I think a lot of that may be dependent on how we go through this latest problem of increase in it, and businesses that may shut down, where there may be need for an emergent relief. I think there's talk now of seeing if they can do something even in lame duck that may be limited. My understanding, the last question, and then I know we're coming up to the end, is the taxability of PPE funds. My understanding that the way the current program is created, it's a grant, but you should always talk to your accountant as to how you have to account for this, and any requirements are going to have to show that this money is actually going to pay employees for payroll. So with that, I know we are nearing the end in the next few minutes. I just want to put up that as a part of the slide. If you have any questions, or you think of other questions after we get done with this is ways you can get a hold of us. If anybody's submitting other questions, that come in after this, we will certainly come in, we answer those tomorrow. I really appreciate everybody taking the time out of their end of their day for this. I hope this has been informative and instructive to you. The slides are there as a resource. There's obviously going to be a lot of intense activity that we will continue to work on going into 2021. But I want you all to feel heartened that the one thing this pandemic has shown is you've demonstrated your value and your importance at both state, local, and federal levels of what pharmacies do. Now we just got to hold them up to the performance and policy making, to the promise of what they say they see us as doing, and keep working towards these policy changes we need. And with that, I know we have maybe about a couple of minutes left. I want to thank everybody for their time. Like I said, this will all be available to you. And this webinar will be available on our site. We have a special partner website. So if you have any colleagues who aren't able to make it, please have them go to the IPC website to listen to this or any of our other informative webinars that are out there. And at this point, I will turn it back to Linda Reedy.
And that concludes our program for the night. Thank you all for attending, and have a great night.